Morning. So since the topics include pediatric surgery, I have requested two of my colleagues, Dr. Siddharth, who's my pediatric surgery colleague here at our institution. I have also requested my former colleague, Dr. Richa Lal. She was the head of pediatric surgery at SGPGI Lucknow. So I would request both my colleagues to give any extra inputs if they want at the end of the presentation. So the topic which we are going to discuss today is congenital abnormalities of the biliary tract. What do we mean by abnormality? There are two terms which we use. One is an anomaly and other is an abnormality. There is a very slight, subtle difference between the two. They are both variations or deviations from the normal. But anomaly word is generally used, although these are not strict definitions, when, yes, there is a variation or deviation, but it doesn't cause problems. It doesn't cause any symptoms. It is not usually considered as a disease, whereas an abnormal is something which will produce problems. So two abnormalities which we are going to discuss today. One is extrahepatic biliary atresia, which is usually called EHPA. That is the term which you will hear. And second is choledochal cyst. So this is my email address. Make a note of it. I'll tell you why you should make a note of it at the end of the presentation. VK Kapoor, .India. So is it extrahepatic? That is the term which has been conventionally used, but actually it's a misnomer, because the abnormality involves usually the extrahepatic, that means outside the liver part of the biliary system, but it can be intrahepatic also. Semantically speaking, it is a wrong term, but that is the term which all of us use, and I don't think there is a change in that. The second part of the term is atresia. Atresia means that there is no lumen in a luminal structure. So you might have read about esophageal atresia, duodenal atresia, intestinal atresia. Similarly, you have biliary atresia, where the biliary system, which actually should be like a tube having a lumen inside it, is like a cord with a solid cord where there is no lumen. So that is why it is called extrahepatic biliary atresia, although it can involve the intrahepatic biliary system. So I had requested all of you to read. I hope some of you have read this, because if you have read, then you probably will be able to understand more. I'm not going to cover each and every aspect of biliary atresia or choledochal cyst. I'm going to explain to you the basics, which will extend beyond these topics also. You must go back and read these two topics into whatever textbook you follow. So what is the etiology? What causes biliary atresia? And it is congenital disease, no doubt about it, but the exact etiology is not known. We don't know. There are various hypotheses, which if you want to read more in detail about EHPA, you will read, but you need to know that it is a congenital abnormality. And the pathological process which results in the symptoms that we are going to discuss are, it's basically a fibrosclerosing. Fibro means fibrosis. There is fibrosis, and wherever there is fibrosis, there is sclerosis. There is thickening of the tissue. For example, when there is a wound, it heals by fibrosis. Then the skin in that area becomes thicker or firmer than the normal soft supple skin. So wherever there is fibrosis, in intestine, if there is an ulcer, it heals by fibrosis. It can cause a stricture. That is what happens in tuberculosis. Now, long-standing biliary obstruction then leads to a phenomenon called cholestasis. Poly means bile, stasis means obstruction, accumulation. The flow is not there. So the liver becomes enlarged, it becomes firm, it becomes rounded, whereas the normal liver has a leafy edge. And then ultimately this increasing fibrosis leads on to what is known as cirrhosis. Cirrhosis means irreversible changes in the liver. The liver parenchyma is replaced to a great extent by cirrhotic process. That is an irreversible process. And whenever there is cirrhosis, it causes obstruction to the portal vein flow. And whenever there is an obstruction to any tubular structure, back pressure increases. That means the tension becomes hypertension. The pressure becomes high. So that is what is known as portal hypertension. In adults, we know that cirrhosis of the liver caused by hepatitis or alcoholic hepatitis causes cirrhosis and then portal hypertension. Children, another important cause of portal hypertension, if you have already covered portal hypertension, is EHPVO, extrahepatic portal venous obstruction, which is a kind of non-development of the portal vein or narrowing or fibrosis of the portal vein, which causes portal hypertension. So in EHBA also, if there is prolonged cholestasis, if it remains untreated, it can cause cirrhosis and portal hypertension. And ultimately, because the parenchyma is being replaced by more and more fibrosis, a stage reaches when the liver fails. The parenchyma is not adequate enough. So that is the end stage liver disease, ESLD, liver failure. The clinical picture is that it is neonate because it's a congenital disease, usually around 4 to 6 weeks, maybe earlier, but usually not at birth. And the neonate is jaundice. What is a neonate? Neonate is up to 28 days, am I correct? And what is an infant? Infant is up to 1 year. Beyond that is a child. So neonate, usually around 4 to 6 weeks, maybe 2 weeks, but usually not at birth, presenting with jaundice. And this jaundice is obstructive jaundice as opposed to medical jaundice. So the urine is dark colored like mustard oil, and the stools are pale colored or clay colored. Whenever there is obstruction to the biliary tree, in adults, the commonest cause of biliary obstruction is CBD stool. So whenever there is obstruction, there could be superimposed infection. An infection of the biliary tree is called cholangitis. Infection of the gallbladder is called cholecystitis. If it is biliary tree, it is called cholangitis. So recurrent episodes of cholangitis. And how does cholangitis manifest? High-grade fever with chills and rigors and increase in the jaundice. So the color of the urine will become darker and stool color, which earlier was normal or pale colored, will now become absolutely white like clay. And the natural history of untreated extrahepatic biliary atresia is, as I said earlier, it progresses to cirrhosis, portal hypertension, liver failure, and death. Untreated, these children would not survive for more than 1, 2, maximum 3 years. So that is the natural history, and that has a bearing on the management, that how quickly you have to institute the management. So how do you diagnose when you suspect that it's a neonate with jaundice and the clinical picture is suggestive of obstructive jaundice? How do you diagnose? So you obviously, in any patient with jaundice, you would do liver function tests. So bilirubin will be raised, but the enzymes which will be raised, as in any other obstructive jaundice, are alkaline phosphatase and gamma glutamyl transpeptidase. These are enzymes of biliary obstruction. On the other hand, ALT and AST, which earlier were called SGOT and SGPT, they are not raised to that extent. They may be raised, but they can go high if there is an episode of cholangitis. So during an episode of cholangitis, even AST and ALT will be elevated. And then because the liver dysfunctions, liver functions are not normal, at some stage, there could be derangement in the coagulation profile. And that is very important to assess in any patient with obstructive jaundice or jaundice, because you are going to do some procedures, as we will discuss later, which are invasive, where you are going to invade the body. And if you invade the body in a patient with coagulation dysfunction, deranged coagulation profile, there is going to be excessive bleeding. So it's very important to assess the coagulation profile. So you do prothrombin time, you do activated partial thromboplastin time, APTT, and then you calculate what is known as the international normalized ratio, INR. Hemogram is not important for the diagnosis of EHBA, but if there is an episode of cholangitis, or if you suspect that there is cholangitis, then obviously total and differential counts will be raised. So they are routinely done. But the diagnostic investigations are imaging investigations, starting from a simple ultrasound, which usually shows that the gallbladder is either absent or small, or it doesn't contract. When you do a fasting ultrasound, then you feed the baby and do a repeat ultrasound, normally the gallbladder should contract and decrease in size, but that doesn't happen. And then there is a classical triangular cord sign, which is that because the pathology is that there is this fibrosis of the bile ducts, the right, left, and common hepatic duct. There is no lumen. So on ultrasound, instead of lumen, the radiologist sees a cord-like structure. And then you can do what is known as a hepatobiliary isotope scintigraphy. Usually it is referred as a nuclear scan, but the correct technical term is hepatobiliary isotope scintigraphy, because we inject an isotope which is taken up by the liver, excreted in bile, and then you visualize it with a gamma camera. Then MRCP. MRCP is magnetic resonance cholangiopancreaticography, which delineates the biliary tree. It is non-invasive, but it is difficult to do in children because it requires long time for the patient to be in that gantry, which is difficult with children. So you have to sedate them. Sometimes you may have to use anesthesia. And in children, obviously, the ducts are very small. And in MRCP, the bile ducts are seen because there is bile in the duct, which is seen as a white shadow in one particular phase of the because of the small size and there is no lumen, it is difficult. ERCP obviously would be ideal because you are putting contrast in the bile duct and then seeing it on an X-ray. But for logistic reasons, technical reasons, small scope, small child, difficult cannulation, requires a lot of expertise. So it's not a very frequently used investigation. And ultimately, we have to do an invasive test, that is liver biopsy. Why? Because we'll come to the differential diagnosis. These are some pictures of isotope scan. You can see the activity in the liver. Normally, you should have seen the bile ducts, and then you should have seen some activity in the intestine because the isotope goes into the bowel. But here you don't see any activity in the intestine. You only see activity in the liver and the urinary bladder. And this is the MRCP film. That is the fluid in the duodenum. So this is the C loop of duodenum, third part of duodenum. That's the gallbladder. You don't see the biliary tree, which normally you should have seen here. You only see a small cystic structure at the hilum. My cursor is not showing on the screen.
It is showing very nicely.
Thank you. So this is the gallbladder. That's the C loop of or second part of duodenum. That's third part of duodenum. You don't see any bile ducts and only a small cystic lesion is seen. This is one of the findings in EHBA on MRCP if it is possible to be done. So based on all this, Kasai, who's the leading authority and after whom the operation also is named, described these variants. One is when only the infracystic part of the CBD is involved. So this is much easier to treat because you have all these patent ducts which you can anastomose. Then you have a type in which only the common hepatic duct is involved, or a type in which common hepatic and cystic duct are involved. These are also correctable because you have a dilated system at the hilum of the liver in both these. But the type 3 is where everything is atretic, where everything is cord-like, there is no lumen. And therefore, this is a non kind of anastomosable variant of extrahepatic biliary atresia. So why is it that at some point or in some patients, we may even have to do an invasive procedure like liver biopsy? Because the differential diagnosis of neonatal jaundice includes number one, physiological jaundice, which as you might have read in pediatrics, is more often seen in premature infants. It is almost always present at birth, and usually it settles by 2 to 4 weeks spontaneously on its own. So that is why I said if the jaundice is persisting beyond that period, you start suspecting, or if it is present, not present at birth and appears later, then you start suspecting that it is not physiological jaundice and it is some other problem, including EHBVA. Neonatal hepatitis, which is a medical condition, which doesn't require any surgical treatment, is one of the important differential diagnoses. And sometimes it is very difficult to differentiate between the two. And that is why you may have to do a liver biopsy. And then there is a variant of choledochal cyst which manifests in the neonatal or infantile type of choledochal cyst, which the child can present with jaundice. But a good ultrasound should be able to differentiate because the extrahepatic bile duct will then be dilated. Management of extrahepatic biliary atresia, once you are sure of the diagnosis, is actually a surgical emergency or urgency, because the longer you wait without treatment, the more damage is caused to the liver, more fibrosis, cirrhosis, portal hypertension, and all. So by the end of 2 to 3 months, the child should, as early as possible, but definitely before 2 to 3 months. So that is why the diagnosis and treatment of neonatal jaundice is a kind of surgical emergency. You have to get it quickly. Now, in some cases, even liver biopsy may not be very helpful. Even a good expert pathologist may not be able to differentiate between the two because there are overlapping changes in the liver. And then an intraoperative or peroperative cholangiogram, IOC or POC, is the investigation which you do during surgery. So through the gallbladder, you put a catheter and then you inject contrast. So here you see that the duct below the cystic duct is seen, but you don't see any ducts. Normally, you should have seen common duct and right and left duct here. So sometimes you have to do, in fact, some surgeons would, as a routine, do a intra or perop cholangiogram to make sure that what you are dealing with is extrahepatic biliary atresia and to decide which ducts are available for anastomosis. And the treatment of choice is what is known as portoenterostomy. Why is it called portoenterostomy? Porta is the entry gate. Porta hepatis, the entry to the liver. This is at the hilum of the liver where the hepatic artery and portal vein are entering into the liver and the bile ducts are coming out of the liver. So the anastomosis is done at the porta. So this is the porta which has been dissected, as opposed to a hepaticojejunostomy. Hepaticojejunostomy we call when the anastomosis is done to the duct. So for example, if the duct is dilated, say in cholangiocarcinoma, say in pancreatic cancer, say because of CBD stones or a biliary stricture, then you have a dilated duct. So that is what is called hepaticojejunostomy. But here, there is no duct. Everything is cord-like. So you have excised that. Now you presume that there are small bile ducts which are opening at the porta. So around that area to the liver parenchyma, you suture or anastomose a limb of the jejunum, which is usually a Roux-en-Y limb, which is used like in any other anastomosis. So that is why it is called portoenterostomy, and this operation goes by the name of Kasai. The problems of portoenterostomy is that these ductules may not be enough to drain the bile from the liver, and therefore the anastomosis can restricture, and therefore the patient can again have recurrent cholangitis with all its consequences. And ultimately, untreated patients, all patients, and some patients who have undergone Kasai also, because of failure of the Kasai procedure, complications, recurrent cholangitis, again cirrhosis, fibrosis, and portal hypertension, may need liver transplant. But the advantage is that Kasai procedure buys you time. The child grows up to a certain age when transplant becomes technically easier. So that in nutshell is what I would like to say about extrahepatic biliary atresia, because I'd like to spend a little more time on choledochal cyst. Or Siddharth, anything you would like to add? Anything which I have missed or I have said wrong?
So I just wanted to know whether we should actually know give significance to this correctable and non-correctable variant, because to my understanding in all cases, that we should be setting in the border and portoenterostomy is
even in uncorrectable. Okay. Okay.
The most common variant is
Yes.
the uncorrectable one.
Yes.
And what I have read is the mistaken, and I want you to help us with that. But even in the correctable variant, I've not proven an analysis for the existing there.
Yes,
it's an
yes.
ongoing inflammation problem.
So what Dr. Siddharth is saying, that even if you have the ducts like in type 1 and type 2, because the atretic process may later on extend to these ducts, in all cases you excise the cord-like structure, and in all cases you do a portoenterostomy. Dr. Richa, you would like to add anything before I move on to choledochal cyst? Can you please unmute yourself? Yes.
So you have explained the basic concepts very nicely. You please finish the choledochal
just
cyst.
1 minute. Can I increase the volume of this? Richa, can you please speak closer to your microphone and little louder, because we are working on a different system today.
Sir, you have really explained the basic concepts very nicely for the undergraduates. And the only message that I would like to re-emphasize, which you have already mentioned in your talk, is that at the level of undergraduates, even if you can suspect that a baby has biliary
Sorry,
atresia.
Richa, there is some technical issue here. We are not able to hear you very loudly. Even I am not able to hear you
Sir,
very
you
well.
please carry on with your
if
next
you would
talk.
like to maybe write your comment in the
yes.
chat box, then I'll read it out to the students. I'm sorry, we are in a different room today, actually.
Okay, sir.
Usual.
Okay, sir. Okay, sir.
So we move on to the next part, which actually is more common, choledochal cyst. And so what is choledochal cyst? Actually, now more and more surgeons prefer to call it biliary cyst, because choledochal, what is choledochal? Choledochus is the bile duct. And this anomaly or abnormality involves the intrahepatic ducts also, not only the extrahepatic. So many people now prefer to use the term biliary cyst, but conventionally we all call it choledochal cyst. Again, this is a congenital disorder, but as opposed to extrahepatic biliary atresia, which almost always manifests in the first few weeks of life, choledochal cyst, although it is congenital, may not manifest or does not necessarily manifest in neonatal period or in infancy or in childhood. There are a good number of adults who for the first time come with symptoms in adulthood, even as late as middle age or elderly. So although it is congenital, but not necessary that it manifests in an early age. And it is a cystic dilatation of the biliary tract, which again can involve extra as well as intrahepatic parts of the bile duct. And it could be single or multiple. One of the common, it is congenital, but one of the common etiological factor which is frequently seen in these patients is an anomalous pancreatico-biliary ductal union. As you all know, the common bile duct and the pancreatic duct, they join to form a common channel called ampulla, because it is little dilated. And then this ampulla opens into the duodenum on the medial wall of the second part in a small projection called papilla. Normally, this common channel is short and it is all within the wall of the duodenum. If it is long, longer than 10, some people say 12, some classifications say 15. And more importantly, if it lies outside the duodenal wall, then it is called anomalous channel. And what it causes, that it causes the pancreatic juice to reflux back, not reflex, reflux back into the bile duct, causing changes in the muscles and mucosa and resulting in its dilatation, which causes functional obstruction. There's no mechanical obstruction, functional obstruction, like what you see in achalasia cardia, like what you see in Hirschsprung disease. There's no mechanical obstruction, but there is functional obstruction. The lumen or the viscus doesn't function normally. And when you look at the pathology of choledochal cyst, usually there is no mucosal lining. Normally you should see mucosal lining. So here we see a dilated, hugely dilated the common bile duct, the extrahepatic part. You see the normal intrahepatic ducts, they are normal size. That is the terminal part of the common bile. Sorry, again, the cursor. Can you please? Yeah, thank you. So that's the normal part of the bile duct. This is the hugely dilated bile duct. That's the pancreatic duct. And see this long common channel, that probably is the duodenum. So it will open somewhere here. And this is one of the etiological factors or associated factors in choledochal cyst. Clinical features, it's not a extrahepatic biliary disease. Atresia also was a rare disease. This is also not a common disease. And for some unknown reasons, it is more common in East Asia, including Japan. Females are more often affected than males. Again, the presentation is with obstructive jaundice, so yellow eyes, high-colored urine, pale-colored stools, and pruritus. What is pruritus? It is not pruritus. It is pruritus. Pruritus is itching. But how is it different from itching? Itching is with a skin lesion like scabies. If you have skin lesions and itching, then it is itching. But pruritus is without a skin lesion. And the hypothesis is that it is because of deposition of some substances like bile salts in the neurons or neural ends in the subcutaneous tissue, but nobody knows the exact etiology. Then when you examine a patient with choledochal cyst, obviously you will find icterus. So the symptom is jaundice, the sign is icterus. And in a child more often, or in a thin-built adolescent or female patient, young adult, you may be able to palpate a lump, but that is not very frequent. Again, if it is long-standing jaundice because of cholestasis, there could be hepatomegaly. The liver is enlarged, and if you feel it at operation, it will be firm and the margins will be rounded. And because of portal hypertension, there could be splenomegaly, and because of liver dysfunction, there could be ascites. But these are signs of advanced or long-standing disease with long-standing jaundice and recurrent episodes of cholangitis. Like all other congenital anomalies, both EHBA and choledochal cyst, you should carefully examine the child or the patient for any other associated anomaly, because multiple anomalies are not uncommon. So the classical triad of choledochal cyst is pain, jaundice, and lump. But remember, that is not seen very frequently. It could be seen only maybe in about 10, 15, 20%, more often in children rather than in adults. In adults, to have a palpable lump is very, very unusual. And again, because although there is no mechanical obstruction, but there is functional obstruction, patients have recurrent cholangitis. The commonest cause of recurrent cholangitis in an adult is CBD stone. The next common cause is choledochal cyst. And then, of course, malignant biliary obstruction. So symptoms are same: high-grade fever with chills and rigors. There are very few conditions which cause high-grade fever with chills and rigors. Urinary tract infection, biliary tract infection, malaria. These are common conditions which you should think of if there is high-grade fever. As opposed to a common disease in our population, tuberculosis, where fever is usually low-grade with evening rise. And then cholangitis typically, and many examiners are very fond of asking these names. There is a triad called Charcot's triad, which is pain, jaundice, and fever, high-grade fever with chills and rigors. And patients who have very severe cholangitis, known as suppurative cholangitis. Suppurative means that bile has now become pus. There is frank pus in the biliary tract. These patients are very sick. In addition to the triad, they have altered sensorium. So they have drowsiness, even comatose, and they have hypotension because of systemic sepsis. So that becomes a pentad. There are very few pentads in medicine, Raynaud's pentad. And these patients require very quick, urgent intervention in the form of drainage of the biliary tree. Otherwise, they can even die. So when should you suspect that there could be a choledochal cyst? If you have a child, infant or child, and the patient has jaundice, you must think of choledochal cyst as a possible differential diagnosis. Of course, it could be medical jaundice also, and more so if there is cholangitis. So if there is a child with jaundice and superimposed cholangitis, the commonest cause probably would be choledochal cyst, because stone disease at that age is not so common. In adult, it is stone disease. If you have a lump palpable in an upper abdomen in a child, again, choledochal cyst should come to your mind and you should try to look for it. And another manifestation is recurrent episodes of acute pancreatitis. Choledochal cyst is a cause of acute pancreatitis. So if a child has in adult, recurrent acute pancreatitis is usually biliary or alcohol. Choledochal cyst also comes low down in the list, but in child, if you have recurrent episodes of acute pancreatitis, you should think of choledochal cyst. And in adult, as I said, that recurrent cholangitis, if there are no stones, and if you see a dilated CBD, but there is no obstruction, that means there are no stones, there is no tumor, then you should think of choledochal cyst. And again, recurrent acute pancreatitis. In many patients, choledochal cyst is missed even after all the investigations, even during surgery. So cholecystectomy is done and a dilated CBD was either not picked up or ignored. And then later on, the patients present with cholangitis. So again, investigations are liver function tests, and the classical finding or confirmation of any obstructive jaundice is intrahepatic biliary radical dilatation on ultrasound, easiest, or CT or MRI. If you have jaundice of about 2-3 days duration, you do an ultrasound and there is no IHBRD, then it is very, very unlikely that this is obstructive jaundice. In the first few days, it may not be there, but after 2-3 days, there should be intrahepatic biliary radical dilatation. And the classical finding is that you see a dilated CBD, but you don't see IHBRD. So this is known as disproportionate dilatation of the bile duct. If the bile duct is dilated, suppose there is obstruction, bile duct will be dilated, but correspondingly, the intrahepatic ducts are also dilated because it is a back pressure. Here, classically, the extrahepatic bile duct is dilated, but intrahepatic biliary ducts are not dilated or not dilated to that extent. So disproportionate dilatation of a part, usually extrahepatic of the bile duct, is the key feature of choledochal cyst. So this is a hugely dilated common bile duct, which is seen like a cystic structure on ultrasound. And the colors you see indicate that this is a Doppler ultrasound where even the vessels are being seen. So how do you diagnose? Now there are reports that a good prenatal ultrasound can pick up a choledochal cyst even in the fetus. And it can even be detected during the intrauterine period. But of course, you do an ultrasound, and the key investigation for diagnosis and evaluation of choledochal cyst is an MR cholangiogram, like here. So see this hugely dilated common bile duct, common hepatic duct, extending somewhat into right and left duct, but look at the intrahepatic ducts, they are not proportionately dilated. So this is the classical picture of a choledochal cyst. And in a neonate, because as I said, MRC may be logistically difficult, you may do a isotope scintigraphy. So again, you see a dilated, hugely dilated duct. In adults, ERC, but today you must remember that for any patient with jaundice, endoscopic retrograde cholangiopancreaticogram is not favored as a diagnostic investigation because you have a non-invasive option of MRCP. ERCP today should be only if you are planning a therapeutic intervention, like removing stones, like draining the bile duct to take care of cholangitis. So diagnostic ERC today is not recommended. So again, when to suspect on ultrasound, if you see a dilated CBD, no IHBRD, and even LFT is normal. That means there is no biliary obstruction. So that is where you should suspect that it could be a choledochal cyst. And if for some reason you have done an MRCP and you see that anomalous junction of pancreatic and biliary duct, long common channel, then you should think that there could be a associated choledochal cyst. So these are the types, and the names you have to remember are, I will explain in the. So type 1 is extrahepatic bile duct. Type 2 is actually a diverticulum. So bile duct is normal, but there is a diverticulum. Type 3 is only dilatation of the terminal part of the CBD, that is the choledococele. Type 4 involves intra and extrahepatic multiple. And type 5 is pure intrahepatic multiple, also known as Caroli's disease. So the original classification was given by Alonso Ledge when there were only 3 types, and then Todani added 2 more types. So this is what it is. So these are different types. This is multiple intrahepatic cystic dilatation. See the extrahepatic duct, it is normal. So this is type 5 Caroli's disease. Now, a very important point in clinical practice is to differentiate, because in choledochal cyst also, because there is biliary stasis, stones form. So how to differentiate it from CBD stone causing dilated CBD? Sometimes it is very difficult, but the features which I described, disproportion, and then if you remove the obstruction, you remove the stones, then if it is obstructive dilatation, it should disappear. The CBD should come back to normal in a few weeks' time. But if it persists, then it is a choledochal cyst. I will skip some of this. The treatment is excision with hepatico. Now here it is hepaticojejunostomy, because you excise the dilated part and then you anastomose a loop of jejunum, rule loop of jejunum to the normal part of the choledochal cyst. That is possible if it is only extrahepatic. But if it is extra and intrahepatic, then obviously the intrahepatic part cannot be excised. So you have to accept that some dilatation will remain. But because you are providing good biliary drainage, the symptoms would resolve. In some patients, especially the type 5 or multiple intrahepatic choledochal cyst, if it is confined to one lobe of liver, you may require to do a liver resection. If it is bilateral, there is no option other than liver transplant. And also untreated or inappropriately treated choledochal cyst, recurrent cholangitis, fibrosis, cirrhosis, portal hypertension, liver failure, ultimately may require liver transplant. But for the common garden variety of choledochal cyst, the treatment is excision with hepaticojejunostomy. So this is the cyst, that's the cystic duct, this is the gallbladder, and the ducts above this were normal, and that is where the anastomosis has been done. Yeah, one more last point about choledochal cyst and cancer. Patients with choledochal cyst have a higher risk of cancer. Two reasons. One, because the pancreatic juice is refluxing back into the bile duct. It is causing changes in the mucosa. So hyperplasia, dysplasia, metaplasia, and then carcinoma. And some people believe that inherently the biliary epithelium is more prone to malignancy. So type 1 and type 4. Type 1 is where there is involvement of the extrahepatic bile duct. Type 4 is when there is involvement of extrahepatic as well as intrahepatic bile duct. These are the types which are more prone to malignancy, and the risk increases with age. And this is the reason why even asymptomatic choledochal cyst should be treated, should be operated, because you then tend to decrease the risk of cancer. The other is when there is an anomalous junction of pancreatico-biliary ducts, but there is no cystic dilatation of CBD. So APBDU or APBDJ without choledochal cyst, there is a very high risk of gallbladder cancer. And this is one situation where a preventive cholecystectomy is recommended by the Japanese colleagues. As I said, these anomalies are more common. Both APBDU and choledochal cyst are more common in Japan. So most of the recommendations come from them. So that's my email address, Gaurav. You will collect email addresses of all students who want to read more about choledochal cyst. Send your email address to Gaurav. Gaurav will then send the collective. Who is Gaurav? I was in touch with you. Yes. So please send your email addresses to him. Then you compile a list, send it to me by the end of the week. And then I will send you some more reading material on choledochal cyst from my book chapter. Okay. Thank you.
Recently have one lady having recurrent pancreatitis. Just wanted to share with you and
So same point, which I said that recurrent acute pancreatitis, you should suspect. So I will read out what Dr. Richa Lal has written. The key message on biliary atresia is have a high index of suspicion for biliary atresia in a good weight, well-preserved newborn. So premature newborn, you can think of physiological jaundice, but if the full-term normal weight baby, uneventful perinatal period and jaundice persisting beyond 2 weeks, by which time physiological jaundice should have settled on its own, with clay-colored stool, which you should yourself see, as she's saying on 3 occasions, and diaper staining of urine. So these are important points. And then LFT shows conjugated, that means direct hyperbilirubinemia, which should be more than 20% of the total bilirubin, and then raised GGTP. And then the second point, she says that unlike other causes of surgical obstructive jaundice, where IHPRD is the as I said, IHBRD is the diagnostic feature. In biliary atresia, you don't have IHBRD because the ducts are atretic. And then she says that every newborn with jaundice, this is when you become a doctor, you should give vitamin K 1 milligram per kg, 3 doses, so that the coagulation disorder related problem and the most dangerous complication she has pointed out is intracranial bleed. So suppose you are in a place where you cannot handle extrahepatic biliary atresia or neonatal jaundice, you would obviously refer the patient to some other higher center. But before referring, she advises that there is no harm and you should give vitamin K 1 milligram per kg, 3 doses. That will to some extent take care of the coagulopathy, and the child in the meantime would not have any serious bleeding problem. Okay. Sorry, I have exceeded the time a little bit, but any questions? Any clarifications? No? Okay. So in case you are interested to read more about choledochal cyst, I will also along with that send some general chapters on how to present a history, how to present an examination, how to answer questions in the examination. So if you like the format and you want to read more about other conditions, then individually you have to email me requesting for which chapter you want. I can't provide you the whole book because I am under a contract with the publisher, but I can give you individual chapters. Thank you. Thank you, Dr. Richa, for joining. Thank you very much. I think we will then close. Sorry, we could not hear you, but I have read out your observations and comments to the students. We will close the session.